Good evening, everyone. I'll begin by extending my thanks and gratitude to the panel and to the scientific committee for giving me the opportunity to present here. The topic of my presentation is outcome of pneumatic displacement in submacular bleed without using tissue plasminogen activator. Submacular hemorrhage is seen in cases of age-related macular degeneration, idiopathic polypoidal choroidal vasculopathy, ruptured macroaneurysms, and trauma. It causes profound visual loss and irreversible damage to photoreceptors by the shearing action of the clot as well as toxicity released from the iron of the hemoglobin. Tissue plasminogen activator has been the mainstay of the treatment. There are two routes of administration of TPA that we have seen. Intravitreal injections with conjunction with perfluorocarbon gas, with or without anti-VEGF, and subretinal injections combined with vitrectomy, with or without anti-VEGF injection. Disadvantages associated with TPA injection is the high cost of drug, no established dosage of the drug, low safety margins associated with TPA, and increased chance of vitrectomy-related complications. The objective of my study was to evaluate clearance of subretinal heme by pneumatic displacement and to evaluate increase in best-corrected visual acuity after pneumatic displacement of the bleed. It was a retrospective non-randomized study where 20 patients having submacular hemorrhage were enlisted from the hospital database in last 1.5 years. All the patients had received 0.3 cc of perfluorocarbon gas with or without anti-VEGF depending on the pathology. Paracentesis was done during the procedure to prevent IOP spike, and the patients were asked to maintain a head-down position for 6 to 8 hours minimum for a period of 7 days. Here's the tabulated patient data. I'd like to draw your attention to the second patient. She presented with a vision of 6 by 60 parts with not a very reliable history, where she stated that she had visual decrease in vision for last 15 days. 1 month after injection, the vision had increased to 618 parts. Another patient of trauma presented with subretinal hemorrhage, which occluded underlying choroidal rupture. The patient number 5, her vision increased to 6 by 36 parts. 2 patients were seen to have breakthrough hemorrhage. One was managed conservatively and the other had to undergo a vitrectomy. Coming to the results, the anatomical clearing of heme was noted in 19 patients up to 1 disc diameter after the end of 1 month period. In 2 patients, breakthrough hemorrhage was seen with only one needing vitrectomy, other was managed conservatively, and an increase of BCVA was noted in 17 patients whose macula was not compromised and the underlying choroid was healthy. I'd like to draw your attention to this patient. She had presented with organized clot. So we injected this patient with ranibizumab and perfluorocarbon gas and had asked to maintain the head down position. This is the picture after 1 month period. Her vision had increased to 618 parts. This is another patient. She had a history of trauma. We can see the clearing of the heme and increase in best corrected visual acuity. Another patient of SRNVM, he presented with subretinal hemorrhage, and this is the photograph after 1 week. So, to conclude, perfluorocarbon gas injection with or without anti-VEGF along with patient positioning is a cost-effective and efficacious modality of management of submacular hemorrhage as compared to when used with TPA. It is minimally invasive. It has better safety margin when compared to TPA and is also effective in cases with organized subretinal clot, though it is not very ideal for patients with young patients with formed vitreous or in patients where the peripheries have not been checked. These are my references.
What is one precaution you take immediately when you inject 0.3 cc of gas along with an anti-VEGF injection?
So we do the paracentesis to prevent the IOP spike.
And what do you also look for after giving the injection?
We explain the patient to maintain a position.
On table. Something on table. Once you've given the injection, immediately you ask for something and then you look for a finding in the fundus. So basically you look for disc pulsations. Okay. Right? Because you're injecting roughly 0.3 to 0.4 ml of fluid or something inside, or you're injecting that amount of volume. So that might lead to a very high pressure and the patient might turn up no PL the very next day. So it is very important, if you see disc pulsations, do you do a paracentesis? And anyways, you have to do a paracentesis, but if you see a disc pulsations, you have to do a repeat paracentesis till the disc pulsations, they go away.
Okay, sir.
So you do an indirect ophthalmoscopy on table immediately after the injection is given.
Okay, sir.
So I just wanted to know that did you randomize these patients based on the location of the
So
bleed?
it was a non-randomized study.
So basically it was, so visual acuity can basically differ if you have a subretinal bleed versus a VRV, a sub-RPE bleed.
I have listed a list of patients in whom the visual acuity does not increase. One case was there, she was an old lady, she had trouble positioning, so her visual acuity did not increase much. There was a patient with underlying choroidal rupture, her etiology was trauma, so visual acuity did not improve much, she was not very happy. Another two patients, the macula was scarred due to PCV, so those are the other cases where visual acuity did not improve.
When you are giving injection and gas, which is given first, which is later?
Sir, we injected gas first.
Then injection.
Yes, sir.
Won't you want to inject the injection first, I think?
Sir, we did it as my senior consultant suggested, so he
Okay.
suggested that we inject gas first.
Right.